staging of cataract? It is of course based on the visual acuity. If the acuity is less than 20 by 200, then it is a mature cataract. If it's more than 20 by 200, it will be an immature cataract. If the person can still read at 20-20 distance, then it's an incipient cataract. Okay. So this is what is regarding the cataracts. And one cataract that I forgot to mention is the Morganian cataract. This Morganian cataract, it is a, what is it, a mature, immature, or a hypermature cataract? What cataract is it? It's an important MCQ.
Mature.
It is an hypermature cataract. Okay, it's a hypermature cataract. Where you have brown nucleus that gravitates within the milky white capsule, within the liquefied milky white capsule of the lens. Usually this Morganian cataract, the lens, around the lens area it will be liquefied and the center nucleus part will gravitate down. It will give the milky white appearance. That is the Morganian cataract. That is nothing but a hypermature cataract. In cataract, of course, everybody say you have to go for surgery. What are the indications of a cataract surgery? First, maximum corrected vision. Even if you use glasses or whatever it is, maximum corrected vision. If it's less than or equal to 20 by 50, then you have to operate. If there is visual impairment that prevents the day-by-day activities, that affects the day-by-day activities, or it prevents the person from doing activities, then you have to operate. Then disabling glare. Okay. Then lens diseases, lens-induced diseases, like the phycolytic glaucoma, phycoantigenetic uveitis, those diseases. Then in diabetic retinopathy and glaucoma, depending on the fundus examination, you decide whether the person has to go for a cataract surgery or not. If the person is going for a cataract surgery, what are the possible options that is available? The options available are intracapsular cataract extraction, where it is a procedure of removing the cataract in one piece, along with the lens, along with the posterior capsule is taken out. Usually, the incision will be more, the degree of incision will be more for this. Large limbal incision will be needed. And it is indicated only in severely impaired zonal integrity, and it is contraindicated in children and young adults. Except in cases of traumatic capsular rupture, where there is no other option. Other than that, all these things, this ICCE intracapsular cataract extraction is contraindicated in children and young adults. Then came a better one, extracapsular cataract extraction. It's a procedure of removing the hard central nucleus in one piece. Through the anterior capsule, they operate it, and then removing the soft cortex in multiple pieces. With the retention of the posterior capsule integrity. So the advantage, obviously, it includes a small incision and reduced long-term complications. Better anatomic intraocular lens placement. And the main requirement for this could be the zonular integrity has to be there. Only then this XC can be done. Okay, if all these things are there, then comes something called as the phacoemulsification. What is a phacoemulsification? How does it work? Any idea? It is a procedure of dissolving the hard central nucleus within the eye by the ultrasound. And then after dissolving, they remove the soft cortex in small pieces. It has got the smallest incision possible. Surgery, which is around 4 millimeter. Okay. And of course, as the name suggests, it will be very expensive as it differs from the standard XC. It is ultrasonically driven and hence it will be expensive. Then intraocular lens, usually after it will be placed, most common placement site of intraocular lens. What is the most common placement site of intraocular lens? It is the posterior chamber intraocular lens, that is behind the iris. It is usually placed behind the iris. If the intraocular lens is not placed, then contact lens or thick glasses has to be used. Then if you take the cataract, what are the complications of cataract surgery? Retinal detachment, cystoid macular degeneration, bullous keratopathy, then choroidal hemorrhage, endophthalmitis, posterior capsular opacification, then glaucoma. Right? All these things could be the complications of cataract surgery. Then other things in cataract, a few MCQs in cataract. What is the most common cause of blindness in India? What is the most common cause of blindness in India? It is cataract. Most common type of congenital cataract? Most common type of congenital cataract, it is punctate cataract. Punctate cataract. Then most common type of congenital cataract that presents with visual impairment. Answers, please. It is the zonular cataract. Right? We spoke about the hypermature cataract, like hypermature Morganian cataract. That hypermature Morganian cataract, it causes secondary angle closure glaucoma. It causes secondary angle closure glaucoma. Then few this what will be the pattern of cataract in Wilson's disease? In Wilson's disease and Charlevoix's, the pattern of cataract will be central cataract. Whereas in Fabry's disease, it will be propellar cataract. Myotonic dystrophy. In myotonic dystrophy, what will be the pattern? It will be Christmas tree cataract. In diabetes mellitus, it will be snowflake cataract. There are many named cataracts, but you try to remember at least this cataract so that it will be helpful for our examination. Then coming to glaucoma, glaucoma is nothing but an increase in the intraocular pressure that leads to the optic nerve injury and then the vision loss. This glaucoma, it can be either an angle closure glaucoma or an open angle glaucoma. The open angle glaucoma, the cause would be a trabecular meshwork fibrosis. Where the aqueous humor and vitreous humor, they are not able to drain outside properly. That will be the reason for this open angle glaucoma. Whereas an angle closure glaucoma, the possible cause would be a pupillary block. That prevents the drainage of the humor, aqueous and the vitreous humor, and leading to an increase in the intraocular pressure. In open angle glaucoma, the loss of vision will be gradual and it will be painless. In an angle closure glaucoma, the loss of vision will be painful and it will be sudden. The visual problems that can happen with an open angle glaucoma is a tubular vision, whereas in angle closure glaucoma, colored halo can be present. Right? Colored halo can be present. Complications, phacolytism could be the same. Phacomorphism will be seen in angle closure glaucoma. Treatment would be trabeculectomy in open angle, whereas it will be iridotomy or an iridectomy. Or an iridectomy in an angle closure glaucoma. Basically, they are going to open up the pupillary outlet for the drainage of the humor. That is what they want to do in an angle closure glaucoma. Then coming to retina, in that you have to know about retinal detachment. Retinal detachment, usually it presents with floaters in the eye, flashes could be present, and curtain fall will be seen. You see as though some curtain is falling in your eye. That curtain fall will be seen. The different types of retinal detachment: rhegmatogenous retinal detachment, exudative retinal detachment and the tractional retinal detachment. In rhegmatogenous, there will be sudden painless loss of vision. And the most common presentation here, or sorry, the most common cause would be the myopia, trauma, aphakia, right? How do we treat this? We treat by scleral buckling. Okay, you treat it by scleral buckling. Exudative renal detachment, it is also a sudden loss of vision where it is painless. The most common cause, it could be the malignant melanoma of the choroid. Malignant melanoma of the choroid, and the treatment will be enucleation. Right? Tractional, it is a slow, gradual loss of vision, and it will also be painless. The most common cause would be diabetes, and treatment would be vitrectomy. Okay, these are the things that you have to know in retinal detachment. Then coming to two important things, that is central retinal artery occlusion and central retinal vein occlusion. Okay, in central retinal artery occlusion, there will be headache, which is followed by bilateral blindness. And the most common cause would be the atherosclerosis. Okay, and usually on ophthalmoscopic examination, we can have cherry red spots or a boxcar appearance, cattle track appearance in the retina. The CRAO patients, they can present with intermittent jaw claudication. Right? Whereas if you see central retinal vein occlusion, the person will have a sudden painless loss of vision. Along with that, you have dimming of light. And on ophthalmoscopic examination, the fundus will have this tomato ketchup appearance, tomato ketchup fundus. Right, and also macular edema will be there for this patients. Incidence will be more in a female rather than a male. These are the points that you have to know regarding the central retinal vein occlusion. Then you have to know about retinopathy of prematurity. Retinopathy of prematurity, of course, it affects the prematurely born babies and cause both oxygen toxicity as well as relative hypoxia. The baby would have had an hypoxia, right? That also the treatment used for hypoxia is oxygen. Too much of oxygen in turn will also causes retinopathy. Both the things will play a role in the formation of retinopathy of prematurity. How do you treat? Treatment is by photocoagulation. Treatment is by photocoagulation. Then the other thing you have to know in retinopathy of retina is retinitis pigmentosa. It is progressive degeneration of the what? Progressive degeneration of the rods in the retina. these patients will have a problem with the night vision. Nyctalopia will be there. And these patients can present with ring scotoma. That is, the tunnel vision will be there for these patients. And the treatment would be an vitamin A megadose. Would be the treatment of retinitis pigmentosa. Retinoblastoma, I think we discussed it during the pathology session. Then coming to the last topic, that is the retinal dystrophies. Among the retinal dystrophy, you have to know about Best disease. The Best disease, usually it affects the macula. It is also known as the vitelliform macular degeneration, where you have a scrambled egg appearance. That is the yellow or an orange yolk-like appearance, scrambled egg appearance. In an ophthalmoscopy, and also you have a normal electroretinogram and an abnormal electrooculogram. This is the points regarding the Best's disease. You asked me about Stargardt's disease. Stargardt disease. It is the most common form of inherited juvenile macular degeneration. Right? Usually, what will be the appearance? It will be a beaten bronze appearance in ophthalmoscopy. Beaten bronze appearance. Okay. This Stargardt's disease, it will be a normal electroretinogram as well as a normal electrooculogram. This will be the retinal dystrophies that you have to know. Then coming to the next topic, that is the UV of the cornea. In this, you have to know about the uveitis, right? Uveitis. In uveitis, you can have an anterior uveitis, posterior uveitis, intermediate uveitis, and panuveitis. This anterior uveitis, the cause will be mostly idiopathic. And redness will be present along with the loss of vision, and you treat it with cycloplegics and topical steroids. Right? Intermediate uveitis, the cause is idiopathic, and the redness will be absent here, and there won't be a loss of vision, but you will have floaters will be seen in vision, and you treat it with triamcinolone. Posterior uveitis, the most common cause would be toxoplasma infection, and there won't be any redness, and there will be a loss of vision, and you treat it basically with antibiotics along with steroids. Panuveitis, it has to be treated with surgery and steroids, and the cause most commonly it would be the trauma. Redness will be present. Photophobia will be the presentation here, and you treat it with surgery as well as steroids. Okay, this is what will be the points regarding uveitis. Then coming to the ulcers, that is the corneal ulcers. It is an easy question that can be cracked. Bacterial ulcers, fungal ulcers, protozoal ulcers, and the viral ulcers. In bacterial ulcers, the most common cause in India is pneumococcus. right? Generally in the world, the most common cause would be staph aureus. And just like any other corneal ulcer, this will also present with swelling of the lids. Conjunctival hyperemia will be there, ciliary congestion will be there. Phlebarospasm will be there. Right? This is what is regarding the bacterial ulcers. Fungal ulcers, most common cause would be the aspergillus. How the person gets it? Whenever there is a history of trauma with exposure to a vegetable matter, only then the person will have this fungal ulcers. The main clinical feature will be satellite nodes. Satellite nodes, patchy satellite nodes here and there. The nodes like this will be seen in the corneal ulcers, fungal corneal ulcers. Then Wesley's ring, right, and dense suppuration. All these things will be there in fungal ulcers. The main hint they will give you is this vegetable matter. This will be the hint that will give you. They will give you, because if you see how many ever pictures you see, you might not be able to identify. But the one small hint in the question, it will come to your mind. Okay. Sometimes this fungal ulcers, it will be confusing with the protozoal ulcers. So if you know the theory properly, it will be easy for you to identify the picture. Protozoal ulcers, the most common cause of a protozoal ulcer is the acanthamoeba. And here the signs would be corneal melting, stromal necrosis could be there. Epithelial pseudodendritis. Radial keratoneuritis. Right? This could be the possible clinical features in a protozoal corneal ulcer. How about the viral corneal ulcer? The most common cause would be the herpes. Right? In this viral corneal ulcers, the most important clinical feature will be the geographic ulcer. How a world where map will be, it will be, you have map will be there, right? Similarly, just like that, the geographical pattern will be there in the cornea. Then dendritic ulcers. Then reduced corneal sensation. All these things are the features of viral corneal ulcers. Then coming to refractory errors, you know the refractory errors, myopia and hypermetropia. Myopia is nothing but the short sight where you are able to see the things nearby clearly and not the far away things. Hypermetropia will be, I forgot one more. Astigmatism is also there, right? I forgot. Am I audible? Am I audible?
Yes, ma'am.
Okay. Myopia is short sight where you see the nearby things clearly. And hypermetropia is long sight where you see the longer things clearly and not the near ones. Astigmatism, both short and long sight has a problem. Usually, myopia, if it's not corrected, it can develop into a divergent squint. Hypermetropia, if not corrected, it can lead to a convergent squint. Astigmatism, it can go for a maximum astilopia. And you treat myopia with a concave lens. Hypermetropia, you treat it with a convex lens. Astigmatism, you treat it with a cylindrical lens. Okay, this is what is regarding the diseases. The MCQ, a person coming to you with a history of frequent change of distant glass. What you have to rule out in this patient? What is the most common cause? The history of frequent change of distant glasses will be cataract. History of frequent change of distant glasses in a young person, in a young patient. You have to rule out keratoconus for this patient. Okay, you have to rule out keratoconus for this patient. If there is a frequent change of presbyopic glass, what is the possibility? If there is a frequent change of presbyopic glass, it will be an open angle glaucoma. Okay, it will be an open angle glaucoma. These are the things that you have to know for your examination. Then coming to few miscellaneous topics and the MCQs that you have to know of. What is proptosis? It is a protrusion of the eyeball, right? Most common cause of unilateral proptosis, it will be the Graves' disease. Most common cause of bilateral proptosis, it will be the Graves' disease. These two in adult. If you ask me what is the most common cause of unilateral proptosis in a child, what is the answer? It is cellulitis. Bilateral proptosis, what is the most common cause? It is the metastasis. Okay, these are the things that you have to know in proptosis. Then Bite-out spots, I think you already know. What is a bite-out spot? It's a small triangular white patch that is seen in the outer and the inner sides of the cornea. In what deficiency, vitamin deficiency, will you see bite-out spot?
Vitamin A. Vitamin A, ma'am.
Exactly, vitamin A deficiency, you see bite-out spots. Right? Then you have to know about entropion. What is an entropion? It is an inward tunneling of the eyelid. Inward tunneling of the eyelid is what is called as a entropion. The different types of entropion includes senile type. This is the most common variety that affects the lower lid. In the seen in the elderly. Management is basically tucking or either you do a tucking of that particular lid or you do an plication of that inferior lid. or you retract that lid and suture. Okay. The other named procedures include modified Wheeler's procedure, Weiss procedure, Biggs procedure. These are the named procedures that is used in the management of senile type of entropion. How about the cicatricial type? Cicatricial type. In this type, the most commonly affected will be the upper lid. And the cause would be trachoma or pemphigus or Stevens-Johnson syndrome. This could be the cause of a cicatricial type of this entropion, and the treatment usually you do it with an what operation? Very important for MCQ, modified Burroughs operation. Modified Burroughs operation or Joseph's Attles operation or a modified Kittsey's operation. This is an MCQ that they have asked in the examination. Modified Burroughs is used in the treatment of what type? Okay. Then spastic type. It is due to the spasm of the orbicular oculi muscle. This spasm is the one which leads to spastic type, and usually you treat it with a botulinum toxin injection. Botox injection is the one that is a management of spastic type. Then you ask me about the congenital type. It is rare and it has to be present since birth. Of course, congenital means since birth. Etiology we don't know, and the treatment could be plastic reconstruction. Etiology could be plastic reconstruction. This is what is regarding the entropion, that is inward tunneling of the eyelid. If it is an outward tunneling of the eyelid, what do you call it? We call that as extropion. Right? This is the most, the types include involutional, where you have this involution to be the most common form affecting the lower lid in the elderly. And treatment is with a medial conjunctivoplasty. Or a horizontal lid shortening. And Biggs procedure. These are the ones which is used in the treatment of extropion. And then this type, the other type is the cicatricial type. This type is because of the contracture of the skin. And the cause would be the trauma or inflammation. And the treatment will be the excision of the scar. Or lengthening of the lid. By Z-plasty. If you put a Z-plasty, you can easily expand that lid. That is what they mean, cicatricial type. The other types include the paralytic type, Same due to the paralysis of the orbicularis muscle. And T treatment is with tarsorrhaphy. Tarsorrhaphy or lateral canthoplasty. This will be the paralytic type. Congenital type, may be associated with a phleberophymosis. That is, you're not able to retract the ellipse. Phleberophymosis, and obviously surgery will be the treatment of choice. Then any mechanical obstructions due to either a large chalazion or a tumor or a lid edema. Because of all these things, that could be a mechanical obstruction that leads to this extropion. It's ectropion, not extropion, it's ectropion. Entropion. And treatment is obviously symptomatic. You remove that particular causative agent of that problem, and the problem entropion will get settled down. Next, coming to squint. In squint, you have to know about two: concomitant squint and paralytic squint. Right? In concomitant squint, it is mostly developmental. And the squint, the angle of the squint is constant in all directions. With a normal ocular movement, there will not be any diplopia or no false projections will be seen. Usually, the primary deviation will be equal to the secondary deviation. Whereas in case of a paralytic squint, it is basically acquired. The angle is variable in different directions. The ocular movement will be restricted. The person will have diplopia to be present, false projections will be present, and primary deviation will be less than the secondary deviation. Amblyopia will be absent here, whereas amblyopia will be present here. Okay, these are the difference between the concomitant and paralytic squints, which they can ask you in examination by giving you a particular condition. Then regarding the loss of vision, you read about the painful and the painless loss of vision, sudden and gradual cause. It is a chapter that you have everywhere. So you try to read that. I'll tell you a few important things. What is the most common cause of loss of vision in malaria? Answer? Most common cause of loss of vision in malaria is optic neuritis. Okay. Then most common cause of loss of vision in an AIDS patient would be a cytomegalovirus retinitis. In a pregnant woman, it will be central retinal vein occlusion. In an elderly, it could be macular degeneration. Okay, then coming to drugs, very important question. Most common side effect of a topical steroid. Most common ocular side effect. I can say ocular. The side effect of topical steroid is glaucoma. Right? The most common ocular side effect of an systemic steroid is cataract. See, glaucoma is because of the outside problem, right? Cornea, obstruction of the pupils and all those things. So when you apply from outside, problem is outside. Remember, it is a glaucoma. Cornea problem, glaucoma. When you give steroids, systemic steroids inside, through the blood, it reaches the inside of the eye where the lens is there. That causes the cataract. You can remember this. This is an MCQ which they have been asking for such a long period of time. So you have to be thorough with this. Then the drug of choice for acute angle closure glaucoma would be mannitol. The drug of choice for an open angle glaucoma would be latanoplast. Right? And then coming to the lasers, which is very important nowadays. What are the lasers that is used for retinal photocoagulation? The lasers used for retinal photocoagulation is the diode lasers. The laser that is used for lithotripsy would be holmium lasers. The laser that is used for laryngeal surgeries would be the carbon dioxide lasers. Right? Then different types of contact lenses that we have. What is the material of the contact lens? Hard contact lens. Hard contact lens material. It is made up of polymethyl methacrylate. Soft contact lens, it's made up of hydroxy methyl methacrylate. Semi-soft contact lens is made up of polymethyl methacrylate along with silicon. Right? Then intraocular lenses. Non-foldable part, the optic part, the non-foldable part, it is made of this polymethyl methacrylate. The foldable part, it is made up of silicon and hydrophilic and hydrophobic acrylate. Then the haptic part. The lens will be like this, right? This part is the haptic part. The haptic part is made up of polypropylene, polymethyl methacrylate, and a few components of acrylate. So these are the things that you have to know regarding the lens. Then coming to few points or spots that you have to see, and where do we see it? White dot spot, we already discussed vitamin A deficiency. Brush field spot, where do you see? Brush field spot. Brush field spot, it is a whitish gray spot that you see in the peripheral iris, and it is seen in Down syndrome. Right? Then Elsching spot, it is seen in a person who is hypertensive, and it is usually seen as a choroidal infarction. Fishner-Hunt spot, Fissure, cunt spot. It is seen in the old age. It is basically because of the senile scleral plug, because of the hyalinized sclera. And Fuchs spot. It is seen in pathological myopia. It's an important question. Pathological myopia. It is seen in pathological myopia. It is basically a pigmented macular lesion. Then rod spot. It is seen in case of a severe anemia, where you see a hemorrhage with white centers. That is what is called as the rod spots. Then few fundus examinations that you have to know of and that can be asked in your examination. Cattle truck appearance. Cattle truck appearance we already saw now. It is a central retinal artery occlusion. Then gold and thunder fungus. Blood and thunder fungus. It is seen in central retinal vein occlusion. Where do you see a silk shot retina? Silk shot retina will be seen in hypermetropia. Then temporal crescent will be seen in myopia. C-fan retinopathy or a rising sun appearance This will be seen with sickle cell anemia. Then snow banking type of appearance, fundus appearance will be seen in pars planitis. Then candle wax dripping, very, very important MCQ. Candle wax dripping. It's seen in sarcoidosis. Right? Then bilateral multiple cotton wool spots. Bilateral multiple cotton wool spots. It is seen in Proptosis retinopathy.